at least in relatively basic clinics, primary healthcare clinics, can actually implement quite complex protocols. And again, and be trained in adherence, in how to persuade people to adhere, and how to, and there are patient support groups to help people adhere to HIV treatment, just as they might do for other kind of treatments, which are for chronic diseases. And then lastly, I think I want to touch upon just kind of more programmatic issues. You know, HIV's combined many of its programs along with TB programs, for instance, and already does some of the very basic, has already strayed, if you will, again, if that's the correct term, into doing things like blood pressure measurements, etc. So they've learned lessons in how to combine healthcare programs together at the primary healthcare level, and that would be very useful for chronic diseases.
Fantastic. I'll come to you, Toyin, because I think one of the things that we tend to do in conferences like this is we can go so deep into details and get paralyzed with there's so much we need to do, and it's so complex, and if everybody's not a doctor, we can't deliver this care. But if we try to dream a little and said, if in 2030 we are successful, what does that world look like? What are those stories you'd love to hear being told on, here's a beautiful story of the impact we've had over that period?
Gosh, that's the most exciting question today for me. You know, let me go back a tiny bit. When I first started trying to save women's lives in childbirth, I was talking to doctors, and I was talking to the women, and I talked myself
Can you guys
hoarse.
hear okay?
Can you hear me?
No?
I talked myself hoarse. And yes, everybody heard the message, but the indices were just as dire as they had always been in Nigeria. I don't know if you know, Nigeria contributes 14% of the world's deaths in childbirths. And then in 2010, I met a group of midwives, retired midwives, who said, we are ready. There are 4,000 of us, and we are ready to come back into the health system in Nigeria, and we want the government to deploy us and send us out to the primary healthcare centers to deliver women, and we are sure we can save lives. And I went to meet the head of the Primary Healthcare Development Agency, and I said, look, there's these 4,400 midwives. Is there anything you can do with them? And they started a program called the Midwife Service Scheme. Now, that program ran until the beginning of last year. But the strange thing is that Nigeria's mortality dropped by 45%. Now, that program is now rested. And they're trying to restart the program, but instead of restarting it with trained, experienced, 30 years experienced midwives, they're trying to run it as an internship program for newly graduated midwives, something like national service, you know, to go to rural areas. And I'm looking at it and I'm saying, look, when I put midwives back into the government system, I think actually it was the first PPP, but I didn't know what a PPP was then. I just went to the executive director of the Primary Healthcare Agency and I said, take these 4,000 midwives. You know, it worked. Again, about last year, I decided to run antenatal classes. I'm running them in 3 states, and I'm just giving you a pocket of excellence. So they go, my midwives, I have 4 midwives. And in 21 months, my 4 midwives have reached 200,000 women just by giving free antenatal classes in a range of hospitals regularly. The mothers have hit the 8 visits, which is higher actually than the recommendation. I think the WHO just increased focused antenatal care of 4 visits to 8. But let me give you a shocking statistic. We're running classes in Lagos State, in Federal Capital Territory, Abuja, and in Kwara. So a wide range of social demographic, whatever. And in the over 200,000 women, we haven't lost one. My country's average mortality rate today in Nigeria is 1 in 12 in an urban educated area. In a more rural area, it's maybe 1 in 9 will die, and in our northeast, it's 1 in 6. So I'm looking at my antenatal registers, and I'm saying, so what is the difference? Why haven't I lost any of, in fact, I haven't lost a single mother, and we've only lost 1 baby who was the last of a set of quadruplets born at 32 weeks. Wow. So he was actually a stillborn, and the other 3 came out, and they're safe, and they're well, because the mother was informed, she was in the right place at the right time, she had the right trained health worker, she had the financial access to the right care. I mean, it's not rocket science. And if I can do it as a small foundation with 36 staff, I'm thinking, well, why can't the government do it? You know, it's really not difficult. And in the facilities where we're working, they are reporting that the women are coming more for antenatal because they want to come for the class. But the key thing about these classes is that I call it the mama care approach. I've taught our midwives to talk to the mothers with respect. Today is International Women's Day.
Yeah.
It's time for us all to give each other some respect and for governments to respect citizens.
Yeah, yeah.
I don't see it as discretionary. I think it's a right. Respect is a right.
Fantastic. I think you'll find a strong supporter in Dr. Gitai. He's been talking about this particular conference, incredibly powerful. Let me come to Dr. Delano. You know, from where you sit at the WHO, if that's the dream of what we could get to, what's stopping us from getting there, right? So you've spent time thinking, asking these questions from a health systems perspective. Any particular insights you'd like to share?
Thank you for the question, and I think there are a number of factors that are stopping us, and yesterday morning I mentioned some of them in our initial plenary. But from the perspective that has been discussed, I think there are a number of things here. One that I think has been repeated often is about the leadership and governance in our ministries, indeed in our countries, and their commitment to reaching the kind of goals that we want to attain, and their ability to navigate the global sphere to be able to get there. And there are these dimensions that forms a kind of constraint to their getting there. And I think one of the things we need to do is to see how we can learn from various countries as to how best to monitor and encourage good governance on one side, but secondly also, as some countries have been successful in, how best to manage that interface, particularly where we have a lot of global funding influence in our direction and actions on health. Yeah. How we can learn how best our governments can manage that interface effectively and be more efficient in utilizing resources and utilizing what comes out of the external resources that seem to drive so much of this.
Fantastic. Neren, if this is to be successful, it has to cut across the typical silos of the sectors, right? So health cannot be health by itself. It must engage with education, with water and sanitation, partnership. So again, the 17 MDGs must all work across together. Any thoughts on smart partnerships or coordination mechanisms that you've seen that are worth highlighting that you can plant in the minds of the people in the room to take forward? I think Neren, and then we'll come back to you. So
it's to him. Yeah, okay.
Sorry. You can help me.
Well, you'll have to respond from as a long-time civil servant. So.
Looking at both sides of the coin, whether it's private or public. I worked in the public sector before I joined private for many years. I want to point to the challenges. The challenges, I think, in both sides of our countries, public and private, is in the way we go about structuring our organizations, our governments. I worked in the Department of Finance. And in the Department of Finance, as many of you know, you structure your budgets around programs. The government officials and the ministers in charge are measured on programs. The same applies in corporate. Everyone is measured on silo objectives. And this is not ideal. Sometimes we stand up and we applaud when there is cross-pollination across divisions, departments, and ministries even, but that's the exception rather than the rule. So that's for me, that's the starting point for the problem, whether it's private or public. Certainly within the private sector, if you want to ensure a long-term commitment from a company, there are certain things you have to do. And I say this, again, as a public servant coming in only a couple of years ago. Firstly, to try to secure country-level commitment is desirable, but not the ideal that one wants to strive for. One wants to strive for a company to commit at a regional level or a global level. In that way, no matter what happens at the country level, you are not subject to those whims. And I speak to NGOs and governments who seek to partner with the private sector. Having originally operated at country level, I've seen how month to month things change for us. Global or regional demands higher sales targets or cuts in budgets, and our programs are sacrificed.
Yeah.
So the way to ensure that there's a long-term commitment from the private sector is to ensure that you package your program so tightly that it can be sold upwards. It's packaged so well that there are no compliance concerns. We often hear about companies who perform poorly. Those are highly publicized across the world when companies do the wrong thing. But operating in a country, I spend a day a week on average on compliance activities, trying to ensure that things don't go wrong.
Yeah.
And so we need our partners in whatever program we step into to assist us in ensuring that all the compliance boxes are ticked. That is critically important in the way in which we operate in the current environment.
Yeah.
We also need to ensure that when bad times come about, we have thought that through. We've seen in recent times, 2007 to 2009, how the global financial crisis has thrown many good programs off kilter, has resulted in funding drying up for good programs, and setting the world back in terms of the good that we started to achieve when our global economy was performing well. We need to anticipate those bad times and ensure that insofar as we can, we make provision for how good programs are going to continue to be funded through those bad times.
Yeah.
And lastly, tying the compliance issue and the bad times issue together, we need to ensure that when we enter into these partnerships, we're all clear on what we expect of each other. We enter it into a mature manner. I've come across many private companies saying, we will not involve ourselves in building roads and funding education. We pay taxes. That's government's problem.
Yeah.
That is, in my view, a very immature way of looking at the world. It undermines the systems theory thinking, which I'm a strong proponent of. If elements of the system don't have a broader vision, don't see their role in growing the system and expanding the pie, then I'm afraid the system will suffer, and those elements of the system, those companies which have that narrow mindset, will suffer the consequences. So those are some of the observations I've had over recent years. Those are some of the ways I believe if we understand each other better, we can go about having stronger partnerships. And when, unfortunately, conflicts come about, we need to ensure that we've agreed up front on how we're going to handle those conflicts or differing objectives. That's also critically important to the longevity of partnerships.
That's fantastic. Strategy consultants and are trying to advise where sometimes we over-define too narrowly what impact is. But fortunately, left that industry now at Dalberg, where we are focused actually on saying we want to create an inclusive and sustainable world. By definition, you have to start at the ecosystem level rather than at the narrow, you're a pharma company, your job is only to make drugs and sell drugs, do only that. Unfortunately, a lot of the people who are in that space haven't caught up with that thinking, and maybe that's what makes us good at what we do. Let me pause for questions from the audience. We have just a couple of minutes. Desta's looking at me very badly. Lady 1, one question. Lady 2, sorry, gentlemen, I'm going to miss you, and I'll go to Lady 3. Very, very quickly, please.
Thank you. Mine is a comment. My name is Belina Shisia.
Question, very short comment.
Know that many countries still don't believe in it. They think it's substandard care. And if you tell a politician you will do primary health care in his or her area, they want a tertiary hospital instead.
Yes.
What are we doing? Della, you were my colleague. I was a WHO rep for 13 years. What are we doing to hold countries accountable to those things they sign for? CDC, you are a partner. How do you hold them accountable?
Yeah.
We are too polite to tell them they are doing wrong.
All right. Final question here. Here.
Access portfolio at GSK. So my question is, are we doing enough to ensure there's legislation in countries to protect and ensure that these SDGs are implemented long after the funding cycle dries, so that the vulnerable populations are protected when we are out of the picture?
Fantastic question. Should we take comments from left to right? Or responses, comments, responses? Or if you don't have one to a specific question, closing remarks.
Okay. The final comment I want to make it has to do with the previous comments have made, that if we don't realize that whatever we do, and I'm going to pick on my own sector, the health sector, or pick on my own company as a health company, if we don't realize that we are interconnected as systems theory dictates, and if we don't start to contribute not just to the area in which we operate, which in our case is healthcare and the provision of therapies and medicines, then the disease trends are going to force us to do that. As you know, there's a shift across the world from communicable diseases to non-communicable diseases. And a critical part of the response to this shift, to this trend, is the environment in which we live in. So it's not just medicines that will solve the problem.
Yeah.
It is a change in lifestyle. And if we don't start to become proactive in realizing our role within a broader system, a role within a broader environment, then trends in that environment will force us to do that. And if we then still fail to respond to those trends, then again, the consequences will impact us in a very dire manner.
Just to first start with a comment by my former colleague Stella, who is now free to comment.
The shackles are off.
But to endorse the point she raises, I'll be joining you soon and I'll be able to. But to say what we do is to try and keep a number of scorecards around performance that we do with other agencies, with the AU. We have in my department an African Health Observatory that tries to see how countries are performing on some of these things. And we do try to get the message across. We had a visit in Brazzaville from the Minister of Health of, I think it was Chad, and when I presented what his financing of health looked like, which was a 60% out-of-pocket payments for an oil-rich country, he jumped up and down a bit, turned around a bit, but in the end began to see that there was something else they needed to do for that sector to get it going.
Yeah.
So we do that, hopefully in an offensive way as possible until I retire, when I'll be more able to get it across. In terms of health promotion, again, it's a critical area that we've ignored. I think the difficulty is because it must be a continuous, ongoing effort. It must mean that we must have people engage with communities constantly, not just when we want to carry out that immunization or to pass out those condoms or something like that. It must be an ongoing conversation. Yeah. And once we can build that, I think we can begin to make some progress.
I'm going to skip you, Toyin. You'll have final word. We'll come to you.
And I think that it's a shared responsibility among all the partners. I think that it's tough. And we have public health, we do public health diplomacy. I think with IHR, the International Health Regulations, for instance, that was actually, in 2005, that was actually quite a good mechanism, at least when it came to infectious disease and outbreaks. I mean, without naming a country, but when SARS came out, there was not a great deal of accountability for reporting that, and that was a big public health threat. And that same country, when it had avian flu, recently H7N5, changed completely the way it reported. So I think that there are there are mechanisms now that help hold countries accountable. Health promotion, I think, I agree, is absolutely key. The issue, I think, to some extent, may have been that there have been so many obvious health issues that are treatable that people are focused on those. When it's HIV, when it's malaria, when it's TB, there are remedies, or at least there are potential vaccines that can be researched. And there's been a lot of focus on that and less on a broader health promotion. But I think that will shift with the SDGs. But I think that the reason is because there have been so many health issues of a single health issues that can be addressed. Yeah. And my closing comment is that I think that there's another trend that's happening, is that expectations for good health and expectations for treatments are quite rightly going up. I mean, if you look at the number of vaccines that have been produced, I was leading a vaccine trial in Sierra Leone for Ebola with the private sector. And so within a year, we had a vaccine and WHO did a fantastic job as well. We had a vaccine that could be used in Ebola-affected countries. So now there's an increasing expectation of healthcare, both from interventions from vaccines, from antibiotics, but also things like cancer treatments. Yeah. Why should people in Kenya, for instance, the cancer treatment facilities are really not great. If you get cancer in Kenya, it's not a good thing. Yeah. And whereas, in other countries, and I speak actually personally as a cancer survivor when I was a youth. I was treated. I went to the NHS. I went to 5 hospitals in 5 days, and here I am today.
Sorted.
But that would not have happened if I'd lived in Kenya.
Agreed. Arif?
Thanks very much. Thanks very much. I'd just like to, in a sense, echo your comment, because as we develop this SDG partnership platform in Kenya, with a number of private sector partners, with the government and the UN co-chairing, why did we select primary healthcare as the focus? Notwithstanding that the lucrative return on investments are not in primary healthcare necessarily. You're looking at lucrative investments in tertiary healthcare, for example, if you look at the spreads and the margins, for example. But nonetheless, this is about really being true to ensuring that those 45% of Kenyans who live below the poverty line can also get quality primary care. And there may be a stigma to that label, but let's remember there are counties out there where primary health care in itself, at a quality, affordable, and accessible level, is in fact going to be the first thing they've encountered in 50 years of independence. So I think that's very important to stress. The second thing, a few closing points I'd just like to make is let's break the silos. I think societies are artificially siloed, and let's make sure both the public, private, the national, county, the thematic silos are broken. I work a lot in early childhood development. There's about 5 or 6 silos there. And think about the interministerial coordination, but also coordination amongst multilateral, bilateral agencies that have specialist silos in their own systems. The other one is around thinking of moving from funding to financing. Let's get creative. I think that honeymoon is over. I think